Okay, fantastic. So hello and welcome everyone to the first NUPsych event of this academic year. My name is Ratnu. I'm the current president of the Newcastle University Psychiatry Society. Thank you ever so much for joining us on what is quite a cold Wednesday evening to learn more about trans mental health. So I'm going to spend a couple of minutes just talking about the housekeeping, and then we'll move on to Martha, who is one of the doctors who works in the Gender Dysphoria Service. So firstly, who are we? We're Newcastle University Psychiatry Society. We're a student-led, student-run society for all things mental health, and particularly focusing on careers in mental health. So we do things like regular talks and events like this. We have workshops, and we have film nights for students who are interested about the brain. So just recently we did Shutter Island, and we've also done American Psycho. In addition to this, we also have a mentoring scheme, Psych Start, which pairs students with clinicians in the Northeast. So if you're interested in that, have a look at our socials. Our Facebook is @NUPsych. Our Instagram is @Newcastle_psychiatry_society. And our Twitter is NCL We're also a ratified medical society, so you can get a membership for just a £5 for the entire year from the NUPsych website. So just a few kind of housekeeping things. Firstly, just to let you know, the session is being recorded. We hope to put this on YouTube afterwards. So please, act as you would, as if people around the world were watching it. Please keep yourself muted. We don't want to have any kind of unnecessary distractions or anything like that. If you have any questions that you'd like to share, please put them in the chat. So next, we'll move on to introducing the panel and introducing the doctors. So we'll start off with Oscar and Charlotte. Would you like to tell us a little bit about yourselves? You're muted.
You're muted, yes.
Hi, so my name's Oscar. I'm currently a PhD student at Newcastle University, studying kind of trans healthcare and teaching medical students. I also identify as a trans man, and I use he, him pronouns.
My name's Charlotte, and I'm a first year physician associate student at Newcastle and a trainee yoga teacher, and I identify as non-binary and use she/they pronouns.
Okay, Lou, would you like to introduce yourself?
I'm Dr. Lou Sutcliffe. I am a postdoctoral researcher at the Faculty of Medical Sciences. I work in stroke research at the moment, and I am non-binary, agender, and I use they, them pronouns.
Okay, Martha?
Hi, I'm Martha. I'm one of the core trainees in psychiatry at CNTW. I also do a day a week as a trust grade with the Gender Dysphoria Service. So I'm training to eventually, hopefully, become a gender dysphoria specialist.
Excellent. And Michael Shaw.
Hi, I'm Dr. Mike Shaw. I'm one of the consultants at the Northern Region Gender Dysphoria Service. So I work with Martha. I use he, him pronouns. I'm also involved, I'm a psychiatrist by background, so I've got a mental health background. And I'm also involved in medical student and junior doctor training within the organisation.
Okay, excellent. So to start off with, Martha's going to talk us through some of the different pronouns, some of the different kind of terminology that's associated with transgender people. So I'm going to load these slides up and then share screen. Okay, Martha, are you able to control that? Are you able to kind of...
Let's find out.
Yeah.
So I use she, her pronouns, by the way, which I forgot to say in my panicked, I have to think of something to say about myself introduction. So yes, so basically I just want to go through some of the terminology that you might hear tonight, just so that you kind of have a framework for making sense of what people are saying, I guess, in terms of like knowing what they're talking about when they're talking. And that's useful if you understand what things mean. So let's see if I can do things with this. I've clicked on something and nothing's happened, so I'm going to...
I will move slides.
So next slide, please. So as I'm sure many of you know, having kind of turned up to this event, transgender is an adjective, so describing word used to describe someone whose gender identity doesn't correspond with the sex they were assigned at birth. And we'll talk about what those words mean in a second. So next slide. So this is my favorite diagram. It's called the genderbread person. So this is just kind of used to illustrate that someone's gender identity, so their intrinsic knowledge of their gender, so your knowledge that you're a man or you're a woman, or actually you're neither of those things, or somewhere in between those things, or maybe both of those things, is different from your gender expression. So how you're presenting yourself to the world, the clothes you wear, the name and the pronouns that you use, how you're interacting with people. which is again separate from your sex assigned at birth. So when the midwife or the doctor catches the baby that's just been pushed out and goes, yep, that's a boy or that's a girl, and assigns that baby into male or female, or if there's some ambiguity in terms of kind of genitalia and chromosomes into being kind of maybe intersex and it's not so clear cut. And this sex assigned at birth is kind of linked with anatomical sex in terms of the kind of primary and secondary sexual characteristics someone has. But for trans people, if they're transitioning and have maybe had some medical treatment in the form of hormones or some surgical treatment, the anatomical sex might not kind of line up in the same way it would for cisgender people. So if you just click, hopefully some things will pop up. So next, click. So that's all gender and sex stuff. And then this is kind of separate from who you're attracted to, so both sexually and romantically. Click again. Thanks. So that's your sexuality. So bit of audience participation, I'm afraid, in terms of learning the terminology. So sorry, everyone. You just thought you'd get to sit here and listen, but no. So to do the terminology, I tend to go for a bit of audience participation, but we'll try and whiz through it as quickly as we can so we can get to the interesting panel part of the talk. So if everyone kind of who wants to comments in the chat, how they describe this person's gender identity. Obviously in real life, what you do is you'd ask the person how they'd like their gender identity to be described, but we're going to learn the words by using this little gender of person. And if you look at where the black dots are on the scale and kind of type in what you're thinking in the chat. And then we can talk about kind of what the answer is and why the answer is what the answer is. Okay, so we've got someone saying trans female, someone saying C, oh D, sorry, okay. D, okay. So we've got a few answers there, perfect. So, so this person is a woman because their gender identity is that of a woman. And because their gender identity doesn't match up with the sex they were assigned at birth, they are transgender. So everyone who said trans woman, well done, correct. So next slide. Cool. So next one. Again, have a go in the chat if you're happy to. Okay, seeing lots of B's. Fantastic. So the opposite of transgender is cisgender, meaning someone whose sex assigned at birth lines up with their gender identity, and those two things are the same. So this person's a woman because their gender identity is that of a woman, and because the sex assigned at birth lines up with gender identity, they're cisgender. Okay, someone I think is having difficulty seeing the slides, but if you click on next slide for now, and then we can maybe work out their issue. So again, stick your answer in the chat. Okay, cool, some answers coming through. So lots of people saying C, fantastic. So again, we're looking at gender identity to find out that this person is a man, and because the gender identity is that of male and the sex assigned at birth is female, and those two don't match, they're a transgender man. So if you look at gender expression for this person's actually still presenting in quite a feminine way. And that might be because they're not feeling like they're ready to come out, or they're not in an environment or that it's safe to come out in terms of kind of, obviously not everywhere in the world is particularly safe for trans people, or their family and friends around them might not be supportive or not be safe to come out around. So that's kind of worth being aware of. Next slide, please. Oh, I think we've skipped one. If we go back to perfect, okay. So again, stick your terminology thing in the chat. Okay, okay, lots of E's, perfect. So yeah, so like most things in life, gender doesn't fit into two neat little boxes of male and female. And there's you know, a vast spectrum of gender identities. So this person's non-binary because their gender identity isn't solely that of a man or a woman, and there's lots of different ways of being non-binary, and it's kind of very much an umbrella term, and we'll talk about that in a second. But yeah, next slide please. Okay, and then last one, and then the audience participation will die down, I promise, for a little bit. Okay, great. So I'm seeing lots of A's for cisgender man, which is perfect. So this person's gender identity is a man, so they're therefore a man, and because this matches up with their sex signed at birth, they are cisgender. So great, well done everyone. This person's actually presenting in quite a feminine way, and kind of, you know, that might just be how they want to dress at any given moment, but you can also see kind of through drag and performance that people might be dressing in ways that's not necessarily the same as their gender identity, which kind of emphasizes that the only way of knowing someone's gender identity is to ask that person. You can't make assumptions just because of how they're presenting. So cool, next slide please. So we mentioned non-binary earlier, which is an umbrella term for anyone who identifies outside the gender binary of either male or female, and there are lots of different gender identities within this, which I'm sure our panel participants will tell you more about in a little while, if you just click the next slide. Like, again, just demonstrating lots of different ways of being non-binary, and the way people kind of identify within non-binary will be different for different people. So next slide. In terms of pronouns, people often get quite kind of anxious about these, but I think we all recognize he, him, and she, her pronouns from kind of just everyday life. Some trans people, especially non-binary people, might prefer not to go by binary pronouns. Others might prefer the binary pronouns, but a lot of people might use they, them, or there are other non-binary pronouns as well that aren't as common in the UK. I don't think I've not really seen many people who are non-binary who use kind of other pronouns other than either binary pronouns or the they, them pronouns, but are possible. So you might see people using different pronouns. And if you're not sure about someone's pronouns, the best thing to do is just politely ask. And then most people will be very happy you've asked and tell you what they would like you to be using. If you make a mistake at any point about someone's pronouns, the best thing to do is kind of just apologize briefly and then move on with your conversation, kind of without making too big a deal. So next slide. Just kind of a note on how common being transgender is. So around 1% of the UK population has some degree of gender variance. So that is, if you click again, about the same as heart failure and celiac disease, which is stuff that we all know a lot about from medical school and have met people with during our medical training. So it's kind of worth thinking that, you know, it's very, very likely that you have met trans patients and maybe didn't realize it at the time, or if you haven't already, you're definitely going to be meeting some trans patients in your career as a doctor. So it's really important to kind of know a little bit about gender identity and transgender health in order to be able to look after those patients effectively. So yeah, and just, yeah, we'll click. Okay. And next slide, sorry, I forgot to remove that statistic because it's a bit more my other talk. So this bit's going to come at the end, so we'll get rid of the PowerPoint now and hand over to the vastly more interesting part of the evening now that you've got a bit of a grounding in kind of terminology and reference points. So welcome to our panel of experts by lived experience. So thank you very much for all coming, and I'll hand over to you.
So I'm happy to go first on this. So like I said, I identify as a trans man, and I guess throughout my years, or the past couple of years out as being trans, I have experienced mental health difficulties in accessing healthcare and things like that. So I suffer from a condition called EUPD, which stands for emotionally unstable personality disorder, which means my emotions are quite heightened and things like that. And it's been difficult in, I guess, accessing healthcare in terms of a lot of people tend to like conflate my transness with my mental health, but my mental health does not kind of affect my transness, I'd say. Like, I'm pretty secure in my identity as being trans, and I think that the only thing that really gives me any kind of mental health issues or anxieties regarding my transition is just the fact of like obviously waiting for changes to happen and kind of the anxieties around that. But yeah, I think there tends to be quite a lot of microaggressions, I'd say, more than anything, in kind of healthcare interactions, which can really impact the mental health of trans patients and stuff like that. And it's kind of really important that they're addressed. So basically just respecting and using the right pronouns, giving the patient autonomy over their decisions and things like that is so, so important, because, you know, they may be suffering from mental health, like depression or anxiety or things like that anyway, but that kind of microaggression on top of, you know, an already difficult journey, which it, as for most of it, it is quite a difficult journey, is obviously being transitioning and things like that. It can just kind of be like the icing on the cake, and it can make things so much more worse and so much more overwhelming than they need to be. So I think it's really important that, you know, you try to respect the patient and give them as much autonomy as possible in these situations, just in order to, you know, relieve stress and anxiety that they'll already be feeling around the appointment, especially if it's to do with mental health anyway. And try not to kind of put the two together, because for quite a lot of people it is separate. For some people it won't be. It's very much up to the individual and how they're experiencing transition and how they're experiencing their mental health and things like that. But ultimately, I think for a lot of people, being able to finally be who they want to be is quite a liberating experience. So I think it's definitely, you know, important to just keep up that momentum and validate them and things like that. Do you have anything to add?
Yeah, I think yeah, my gender identity is something that I've come to think about more recently, because I think, well, I was thinking a lot about my sexuality, and then I was like, what does it mean to be a queer woman? And then I was like, I don't know, because I'm not a woman. Light bulb moment. And it all kind of fell into place. But I think because like, I think coming to terms with gender identity, sometimes people find difficult when they're quite like you're not admitting something to yourself, and it takes time for people to admit and like come to realizations and be comfortable within themselves. I mean, I think when people are suffering with like mental health problems and low self-esteem and low self-worth and value, I think you can like attach like negative feelings to the things you think about, and also like the like when you've got like low self-esteem, you might think like, oh, I'm not worthy of seeking help or treatment, so people might put doing either their transition or going to the doctor about mental health. And like Oscar said, I think like going to talk to a healthcare professional about either mental health or gender can be a difficult thing. So I think when like Oscar was saying, like people often think like, are you depressed because you're trans, or are you trans because you're depressed? And like I think separating them and like giving, like listening to people, listening to what people say to you, and not putting ideas in people's heads or assuming that the way they feel is because of, I don't know, what you've read, or and also realizing that people's experiences are different, and that everyone's experience is unique, and it's not just because you've met like one trans person before and they said this, and the way they express their self in one way, it doesn't mean that everyone who is transitioning, for example, wants hormones or surgery, and it's not a one size fits all for people. So I think, yeah, like Oscar said, giving people autonomy and respect is really important.
There we go. Okay, awesome. Right, so I think I probably have to do this as a timeline. I had a partner when about a decade ago who was a trans woman, and when she transitioned, I questioned my own gender identity, and I had spent my life not really understanding gender identity, like why a set of rules were applied to me because someone had decided I was a woman and I had to obey them. None of that is ever computed. Where there should be a gender identity in my head, there is nothing. I am a gender. Like it seems like a set of absurd rules to me that I don't see why I should have to follow. But I was not aware that it was possible to be non-binary. Even at the point where my partner transitioned, I believed you could only be one or the other, and therefore I so assumed then, well, I as default I must be a woman. Fine. And then I discovered that actually that was an option. More and more recently, that sort of thing came into the public eye, and I also started making friends with people who had divergent gender identities. And so I would say about 2018, I got to the point where I said, well, if there's nothing here in the head that says what my gender identity is, I probably haven't got one, and therefore I fall under the non-binary umbrella. So November 2018, I started by coming out to sympathetic friends, and as I did so and experienced the gender euphoria of not being seen as a woman, by the way, I do also use a near pronoun, but I tend not to use it in public. I'd say they, them is my work pronoun, if you know what I mean. Yeah, with my friends I use am, a near pronoun. So I, as I experienced gender euphoria, I realized, well, perhaps I'm going to have to do something more about this. I'm not satisfied. I've never been satisfied with my physical appearance. I would say I've spent my life, I had the standard anxiety and depression diagnosis because there was a semi-permanent weight on my head, on my brain. I am, like so many transgender people, I am very likely autistic. I am on a diagnostic waiting list for that as well. But I am diagnosed with dyspraxia. I'm waiting for it to see if I have autism, essentially. I've been accepted on that waiting list. So a lot of rules didn't make sense to me. A lot of neurotypical rules didn't make sense to me as well. So realizing that I was going to have to do something about this, and the fact that the perpetual weight that had always been on me, that had always suppressed any happiness in my life, was starting to lift a little with the use of pronouns. I thought, right, perhaps there's something I could do with my physicality as well. I had a certain amount of experience with understanding how I would need to navigate these pathways. So from my partner going through it, and also from clinical knowledge. And so I went to my GP. I took my best friend along with me and I explained I went to my GP and I said, okay, do you have any transgender patients? And she said yes. And I went, good start. So I then explained to her that I was non-binary. And I said, what options are there essentially to physically degender myself? Can I get rid of everything that is to do with that would be have a gender assigned to it? And unfortunately, I'm not allowed to have no hormones at all, because as we were, that will cause a dangerous bone density loss and other things associated with just removing your ovaries and not replacing them with anything else. So after a certain amount of discussion, I believe that I would if I have to have a hormone, I would rather have the male ones. So my pathway from then on has essentially been the same as a transmasculine one would have been. And I am keeping an eye and seeing whether my dysphoria goes too far the other way. So I asked for referral to the Northern Regional Gender Dysphoria Service, and as I'm sure we all know, the waiting lists are unbelievably long, because I understand there are not the consultants, the trained consultants are not there. Across the country, we don't have the expertise, and we don't have the funding, and we don't have we're not able to see as many people as we'd like to be able to. So I got the referral. I am still on that waiting list. I'm still on your waiting list, but I have been for a year now. I expect to be for a long time. I realized that I was going to have to seek private healthcare, because it was, now that I knew that, it's like when someone opens a door to a cage and now you can't walk out of the cage, but you know the door is there and you can't leave, and it makes it worse somehow. So I saved up money and I sought private healthcare with your GP, the clinic in Edinburgh. When I researched it, I discovered that the main clinician there had previously run the Edinburgh NHS clinics, and therefore I believe that she would be very likely to understand the she would know how to navigate NHS structures, and what anything that she did would be appropriate for any NHS care I needed to have later. So I paid to see her. I explained the situation. I believe that she believes I'm a trans man, and she expects me to end up entirely the other way. If that would be very helpful, that would make the documentation much easier. But as so far I have shown no sign of being a man, I still appear to be nothing. So I went through the diagnosis. I went also to Dr. Kennedy, who was the second opinion. And then I returned to Dr. Mishkoff, who's the clinician in Edinburgh, and I have the requisite 2 opinions to proceed to other things. Since then, I have commenced testosterone therapy. I've been on that since February. And as you can probably hear from my voice, from the changes in my facial structure, my eyebrow position, that sort of thing, I am progressing through that. I have more muscle mass as well. So I am now on a waiting list for a hysterectomy at the Royal Victorian Infirmary, and I am also investigating the possibility of private chest reconstruction. So that is where I am now. I would say I have probably found this a lot easier than most people would, because I know, for instance, what bloods need to be taken if I want my calcium level or my full blood count, because there have been several points where I have seen that I have had the wrong things requested and have had to ask for nurses to use the correct tubes. And also I've been able to couch my medical histories in terms that I think people will understand, and use clinical language and I suspect that I know that my friends who are not, who have no clinical training, have run into far more difficulties convincing people, explaining things, or being believed, in fact. My GP has also been extremely helpful and has agreed to shared care protocols, and has, to the point where the consultant in Edinburgh has been delighted every time I come to her with a full battery of bloods and everything done that should have been done, and that sort of thing. So that's where I am now. I am waiting surgical treatment, which I hope will happen before the end of this year in the case of the hysterectomy and BSO, and at some point next year in the case of the chest reconstruction. At the point at which I have nothing left that could gender me, although automatically people will probably assume I'm a man, and that will do because it is not associated with 37 years of trauma for me, and anxiety, depression, pain, etc. So yes, male will do. I would prefer nothing, but nothing doesn't exist in our culture. So yes, that's the situation I'm in now.
Hi Lou, I have a question for you. I'm going through the exact same procedure for one of my patients, also in Edinburgh.
Mm-hmm.
I've had conversations with Dr.
Mishkoff is excellent. I highly recommend her.
So I'm an eating disorder psychiatrist, and we have very strong connections with the gender clinic in Edinburgh with Dr. Kennedy and the team. And
yes,
I totally understand how many hoops we have to jump through to get any sort of right treatment for the patients. Similar situation,
especially with the comorbidity of the eating disorder as well, which must get in the way. Yeah.
So yeah, exactly. Like it's about gender dysmorphia and gender dysphoria. We're trying to anything you say, they link it. I mean, I'm totally in agreement with what Oscar was saying as well. They try to link everything you say with something else. They say, "Oh, that
I mean,
we have that." You know.
For instance, hip dysphoria, that I always assumed was just a natural reaction to, oh, this society hates fat in any way, therefore I must just be assuming I'm fat. No, it was very specifically those locations that I had difficulty with. So I can see how that would muddle things.
No, but everything you say, they will link it to something else. And, you know, the way you feel about yourself, your gender identity completely gets pushed aside. And so it's been an ongoing struggle, and we're trying to raise awareness about the whole issue of gender dysphoria, gender dysmorphia, gender dysphoria. All of these are separate issues, and they need to be treated separately. And in this process, we are trying to actually validate the issue of how to legally change the status as well. Like you're saying, how do you put a non-binary status on the legal documents, because my patient is still getting referred to as a she, because that was the birth sex, and that's not fair. Everywhere the person goes, we are still referring to them as them, and everywhere they go, the person is getting referred to, like the radiologist is writing letters saying she, and every time that then they come back to the clinic in tears, and we're still having to deal with it. We have raised it several times with several people.
That's the microaggressions.
Are you still in that stage? Are you still in that stage where nothing has been done? Is there any progress at all from your side? You're at a farther along process than where I am. Do you have any answers for me?
So I get a wonderful smattering of different pronouns in my letters. Dr. Mishkov generally refers to me as they.
Okay.
My GP refers to me as they, and to be very good about it. Once Dr. Mishkov appears to have forgotten and referred to me as he. Other clinicians may refer to me as she, but I've had very few clinical letters recently from anything other than. I attempted to give antibodies for a COVID study recently, and had to navigate the blood and transplant service, who said we may not be able to have you on the system because we would need to check your for I guess rhesus antibodies, or whichever one, if you'd possibly had a silent pregnancy. And I said, okay, you can keep me on the system as female for the moment if that means that you get the correct checks done, and that will do. Because male is just as wrong as female.
Yeah.
I have resigned myself, like many non-binary people, to the fact that we will never be correctly gendered in any NHS system because it's not built that way, and we will never be correctly gendered in our binary society.
You said that I will get this person the right pronoun.
Thank you for doing so. Thank you for trying. Yes, it's the microaggression you endure every day, one way or another. Yes, it is very validating when somebody gives you the correct. Dr. Kennedy, for instance, when she was drawing a family tree for my family, and she put my father in as a square, and she put my mother in as a circle, and then she put my brother in as a square, and she put me in a triangle. which is a symbol I normally associate with a fetus of which you do not know the gender. And I was delighted, and I said, I'm a triangle, and she said, yes, I'm doing that now. And I'm like, that's
diamond. You should be a star.
And I was like, I'm a triangle. Which would probably only be amusing to anybody who's actually had to draw a family tree for a clinical reason. But
we do need to change the whole repertoire, and I think it's going to take time. But where do we start? This is the place to start, isn't it?
But I mean, there are Hawaii, for instance, I believe has a third gender on the passport. Some US states have a third gender on the passport. There is legal precedent for it. It's just a matter of, I don't think this government is ever going to do it. They were told about it during the consultation, and they didn't do anything about it. It is perfectly legally possible to do it. It's a matter of the will to have it happen.
I've spoken to health records, for example, in Edinburgh, and they are saying that we might need to apply for a completely new track number, for a completely new patient number. So that makes this all the patient records get archived, and we get a totally new patient number as of a new baby, suddenly appearing like a 25-year-old baby.
Let's hope this person doesn't have any allergies to penicillin or anything else that they may need to know about the previous medical records then.
Which didn't make any sense at all. So, okay, I shall keep striving. Thank you so much.
Good luck to you. I think it's something that requires national legislation, which we're probably not going to get anytime soon.
We will take it up. Thank you so much.
No worries.
Okay, thanks a lot. It's a very interesting discussion. Does anyone else in the audience have any questions to ask the panel? Yeah, so we've got one from Sam.
For me, I've got a very kind of memorable experience of this, and it's been really difficult, is all I can say. So I've been out as trans for a while, but the past couple of years, I've got a condition called endometriosis. which is obviously really painful. My time of the month is already like a really dysphoric thing for me anyway. It's not something that I want to have to deal with. So it's already bad enough as it is. But it finally got to the point where the pain was getting to the point where I couldn't actually like get up or do anything, and I'd just be really ill and sick. So I was like, I have to go see the doctors about this, even though I had put it off because I was scared about what they were going to say to me and things like that. So I went into the doctor and I told them about what I was feeling and the pain I was in, and you know, they pretty much dismissed me the first time. So I went back again. I'm quite persistent and quite stubborn when I know I want like a treatment to something. So I went back again and saw a different doctor and, you know, explained the same things again. And he basically turned around and told me that I was tying his hands because I was making him, like, I refused to take female hormones, basically. I refused to take the pill and stuff like that. And like, I had reasons for it. A, I don't want female hormones in my body because that would make me feel more dysphoric and impact my mental health. And B, I'd already taken the pill before and it hadn't worked. So for me, there was literally no point of even trying female hormones again. But yeah, this doctor turned around and basically said to me that I was tying his hands and basically tried to force me into choosing between my gender identity and my treatment for my endometriosis, which I totally kicked off at. Obviously being a bit more knowledgeable about like things and like that, I kind of turned to him and said, well, you know what, if you aren't willing to deal with it my way, you can refer me to gynecology. And so after a bit of to and fro, and I eventually got my referral to gynecology. And obviously I was very worried about, you know, what we're going to say, because that experience was really horrible and negative for me to kind of experience. And it made, like, I remember coming out of that appointment crying because like it just made me feel completely broken inside. And so I was really nervous about going to gynecology. And when I went, I was absolutely astounded. The doctor came out, she used my correct pronouns and name to call me from the waiting room, which was already like a fantastic start. I don't normally get that, so that was amazing. She then sat me down, asked me what was the problem. Obviously she could see it on my record. And she was just like, well, yeah, it's really stupid that they're asking you to take female hormones when you're clearly not wanting female hormones. And I kind of done my own research with her as well and stuff like that. And we came to a treatment plan, which was to use a kind of old school endometriosis treatment, which is something called danazol, which kind of has masculinizing side effects, which is why most cis women didn't want to take it. But for me, that was kind of like a, yay, I don't really mind about them side effects at all. And basically started me on that straight away. And basically told my doctors to kind of carry on this treatment, and if I had any problems, just to come back to her straight away. So for me, that's like the two kind of sides of the coin. One where I had a really, really negative experience, and then one where I had a much more positive experience because I was respected, I was given autonomy in my decision making and things like that. And it really, like, I came out that appointment smiling, grinning, and that was like the best feeling for me, to be able to actually get rid of the pain, carry on with my everyday life, but not kind of jeopardize how I felt about my gender identity or the impact that that would have on my mental health as well. So I think, yeah, definitely the second appointment I had with the gynecologist was a lot better, but kind of that's my main experiences and things like that. In terms of screening, I know that I guess I'll be due a smear test soon because I'm coming up to 25. And if my gender marker gets changed to male before then, I probably won't get sent a letter to request a smear test and things like that, which is kind of problematic. And I know that some of my friends who are trans have got, one of my trans friends who's a trans woman got asked, sent a letter for a prostate exam and stuff like that. And it's just like, okay, which is fine. But like some of my other friends, so one of my trans women friends got sent a letter for a smear test, and obviously she doesn't have a uterus, so there was no need for her to go do that. But yeah, it's just that kind of thing. But there's definitely ways to act that can make sure that what could be already quite an anxiety producing situation and an uncomfortable situation, especially when you're dealing with I guess, parts of your body that you don't kind of associate positively, and they're quite negative aspects that you kind of have that attachment to. There's a way to deal with that in a way that makes sure that the patient's still validated, that they don't leave there feeling upset or kind of invalidated, or their experiences and things like that. There's definitely a way to do that. So I don't know if Lou has anything to add to that.
I wonder if Charlotte did actually as well, because I imagine that applies to Charlotte too.
You get asked if you're pregnant.
Oh yeah, I had to go for a Hep B vaccine with occupational health, which was, I mean, very important and useful. But the appointment took ages because the poor nurse got very confused as to, because we were just making small talk, because like, I mean, I hadn't spoken to anyone in a while because it was lockdown, and then had mentioned my boyfriend, and then she was like, oh, is there any chance you could be pregnant, like going through the questions? And I was like, no, definitely not. And she was like, oh, well, you're not on contraception, so how do you know? And I was like, my boyfriend's trans. And she was like very confused. And like, I've had that in like sexual health like screenings, and like I used to take the pill as well for like my cycle, and stopped taking it for various reasons. But when I'd had a review, the nurse was like, oh, how's it going? And I was like, oh, not great, like my cycle's really heavy again and it's bad. And she was just like, oh, are you taking it properly? And I was like, what do you mean properly? And she was like, do you take it at the same time every day? And I was like, well, not really, to be honest, because I wake up at different times every day. And she was like, well, you're probably going to get pregnant. And I was like, probably not. And she was like, why? And I was like, because I have a girlfriend. This was a while ago, by the way. This was a separate partner. Probably should have clarified that. And she was like, right. But I think it's just the assumption that, because I think like it's both with gender and sexuality, because I mean, I know this is more about gender than sexuality, but I think most people are assumed to be cis and straight. And then if you're one or both of those things, and sexually active, I guess. So if you kind of fit on anywhere on the ace spectrum or the gender spectrum or the sexuality spectrum that's not like sexual and heterosexual and cisgendered, then it kind of confuses people. And like Oscar was saying, like people being invited or not invited for certain screening tests, and like obviously they're sent with good intentions, because it's good to have like a mammogram or a cervical smear test because they're for your benefit, but it's just about making sure people get the right treatments for their health, rather than like, and I think if they were kind of like sometimes like on the MLE, like some of the gynae stuff is written as like women's health, and sometimes it's written as gynecology, which I mean translates as like women's health. I think like if it was maybe called like reproductive health or like uterine health or something that was less like gendered, it would be better, because you don't think like uterus, pill, woman or whatever. You think like body part, because they're just body parts at the end of the day.
So for one of the things that I would potentially need to be screened for, breast cancer screening. So I have a very utilitarian view of this. I have parts that might go wrong. If I need to get them checked, I'll get them checked. I realise that that is not even said. I am aware of cis women who are terrified at the idea of and never go for cervical smears. I'm aware of trans men who are terrified and really hate the idea of going for cervical smears. I have never been that bothered by cervical smears. I feel at home in a clinic room. They're getting a thing done, and that's fine. Okay, carry on. I'm hoping to have the whole system removed, thus removing the problem entirely anyway. I appear to be at a slightly high risk of cervical cancer. I've had some karyotic cells before now. I'd like it all gone to remove that risk anyway. So hopefully that won't be an issue anymore, as will the things, terrible things where if you occasionally, if you're on testosterone too long, your endometrium starts to go crazy and bleed everywhere. I understand the recommendation is that you get it taken out as soon as possible, and I intend to do so because I don't want it. But that may be different for trans masculine people who actually may want to have their own children using their uterus, which I do not. Breast cancer. Anyone can get breast cancer. If you've got breast tissue, you can get breast cancer. Men can get breast cancer. It's just less frequent. Cis men can get breast cancer. It's less frequent. I would imagine, again, I intend to get that tissue removed. That would probably greatly reduce my need for a mammogram. If they still want to check me, okay, you know, if there's breast tissue, we can still get breast cancer. Fine. I will not have the same attitude to this. I have a very utilitarian view of getting things checked out. But I'm hoping to remove all that tissue and avoid the problem anyway. My trans woman partner, upon her changing her gender within the NHS system, immediately being well over 25 at this point, received a letter saying, please come for a cervical smear. And the next day we received a letter saying, we have been told that you either do not have or have never had a cervix. And therefore, please ignore the previous letter, which we found very entertaining and she considered framing. Yes, I will value my health before being very, very angry about. I'm not happy about being misgendered in that way, but I also don't want to die of cervical cancer. So there we go, you know.
Okay, thanks a lot. Does anyone else in the audience have any questions for the panel? Well, I have one. So you've spoken quite frankly about some of the challenges that you faced. Okay, right. Sam's got one more question.
Yes, I can probably answer that quick one. That varies wildly depending on which region you are in the gender dysphoria region for. Some people report up to 5 years. I would say probably a minimum of 1 year. But I think you probably want to talk to somebody in NHS Business Authority or whoever does the statistic to tell you just how long those waiting lists are. I would imagine the clinicians who work in the Northern Regional will be able to tell you far better than I can.
There is, I think, Martha
sure, yes.
slides on it.
I did stats recently, and it was between about 3 and 5 years, but a lot of the services were suspended due to the pandemic. So a lot of those things have increased. And like, if people don't know, you have to get 2 opinions before you're allowed to start treatment, and often you have to wait a long time to be seen by one person, and then even longer to be seen by another person. So by the time from like the GP to getting your end goal, whether that's like gender therapy or hormone treatment, is even longer than it seems.
Yeah,
look at it straight away.
Which
yeah,
is
it's definitely
basically ridiculous, because you can just start a GP could start you on hormonal therapy. It's complex, but not beyond the average GP by any means. Like,
well, it's funny because like I could go and get the pill tomorrow, but if I wanted to start tea, it would take me like 5 years, and they're both hormonal treatments, but obviously for different things. But like, yeah, the whole system's very like controversial, I guess. Like, but I mean, obviously there are things that could be done about waiting lists, but it's just time and money, resources, budget.
And I understand training consultants as well. The expertise is not there. That was what I was told by Cumbria, Northumberland and Weir when I was a city councillor. They were finding it very difficult to hire consultants who were sufficiently experienced in the area.
Yeah, definitely. And I think in terms of like the waiting as well, it's such a long process, and obviously I would say for me personally, the waiting has been, I've been on the Northern Gender Clinic list like two and a half years, something like that. But I spoke to Lou before, and Lou recommended your GP, and I have went through them while I'm on the waiting list for the Northern Gender Clinic. So hopefully the Northern Gender Clinic will take over my care once that goes through. But I started testosterone last week or something like that. So I'm very, very early.
Yes,
and
the waiting lists for your GP are in the order of 3 months to see a psychiatrist, rather than for a second opinion, rather than. And even that was like, they were apologizing for the length of time, and I was like, well, comparatively you're doing very well.
So it is a long time, but most of it is kind of underfunding from the government, underfunding of resources. Everyone that I know who either works in the gender clinic or is interested in trans healthcare all wants the same thing, like trans patients as well. We all want to kind of reduce these waiting times and reduce the kind of stress that people get. And I think one of the great things is doing events like this and kind of raising awareness, because the more awareness we have, the kind of more pressure, I guess this is coming from like a sociology point of view, but the more pressure that we can like kind of put on the government to call for change and you know, things like that. And especially with the current GRA kind of act being scrapped a bit, it's, you know, it's now more than ever that these things need to change. And, you know, a lot of trans people are turning to private services in the interim in order to access hormones earlier. Like I said, I'd started my PhD this year, was great, but I felt like my life had kind of stopped with my transition. Like the rest of it was progressing fine, but I felt like I was stuck in like where I couldn't move on with it. And
you're in a sort of hiatus, aren't you? A limbo,
yeah,
while you wait to what you become, what you could be.
Yeah, and there's so much uncertainty about kind of what will I be, and it does add this kind of extra stress or like existential stress that you get on top of, you know, already having dysphoria and things like that. So I think, you know, it's events like this to raise awareness is so important for kind of moving that forward and kind of breaking these cycles down and putting pressure on the government to start actually funding NHS services across the board.
Well, there's a point, maybe I remember we were talking to Martha about something, and she was saying that it's actually really hard to even start training for it. I mean, obviously Martha can speak about this more than I can for Martha, but it doesn't seem like there's a clear pathway to become working in gender dysphoria. So from an internal way looking at it, there might be like hundreds of doctors and junior doctors and stuff around the country that want to specialise in gender dysphoria services and become dysphoria consultants one day, but there isn't that defined pathway like there is to become like a cardiologist consultant or whatever. So even that might, the change in the internal system might help. When more people get trained, then there'll be more people to do the job.
Yeah, someone asked in the chat about routes into gender medicine as a specialty or special interest. So is it okay if I co-opt the panel slightly?
I'd be fascinated to see.
Seeing as I'm finding my own route into gender as a specialty. So like the typical route of entry at the moment is to be a consultant in something else, which is normally like, which can be anything, but a lot of the time is psychiatry or GP, possibly endocrinology, or I think we've got a sexual health consultant as well at the Newcastle clinic. So to be a consultant in something, and then to be like, oh, this looks interesting, I'm going to go and learn how to do gender, and then kind of get a job at a gender clinic and kind of learn on the job and get trained up on the job, which is a bit of a weird entry field to a specialty, really. So things are like, my job at the moment is very much kind of like a pilot, I guess, in terms of the idea is that I'm doing psychiatry core training in parallel with spending a day a week with the gender dysphoria service. So at the end of psychiatry, you know, core and registrar training, I come out as a consultant psychiatrist, but as someone who's got like a really good amount of gender dysphoria experience and can go into it straight away being a gender dysphoria consultant who knows what they're doing and can do all the referrals and hormones and everything that people need to be able to do. But this is very much a route that I've kind of carved out for myself, I guess. So at the moment there is no real typical pathway into it, but I guess if my training pathway works, then there's the scope for the clinic to start thinking about having more trainees as part of their kind of model. And I suppose the other thing that you could do is, at least for psychiatry, I know you get some special interest time as a registrar, and we do at the clinic, there are special interest registrars who can come and spend there. I think you get like half a day a week or something, and you can choose to kind of come and spend that at the clinic. So that's kind of another way of getting some experience. But yeah, it's a bit weird at the moment because you kind of have to carve your way into the specialty, and kind of make a path for yourself rather than fitting on something established like you would do if you were like, I want to be a cardiologist, so I'm going to do core medical training and then cardiology registrar training, and oh look, I'm a cardiologist at the end, kind of thing. So
we need some gender dysphoria regis, please. I think, yeah.
Yeah, but yeah, working on it. Okay.
Do you want me to say a couple of things about medical training? From our point of view, having helped Martha carve out her training program, which required a lot of negotiations, so within our organisation, I think it's worth saying that. So we're reliant on people developing transferable skills that they can then bring into the field. So I know there's some controversy about whether so many mental health specialists should be working with gender dysphoria. It doesn't have to be, and there are certainly other areas of medical training which would lend themselves. So endocrinology, sexual and reproductive health, general practice is a perfect one. It's somewhat easier with some training schemes than others, and as we're hosted within a mental health trust, it was something pragmatic. But we're a psychologically informed service, so there are transferable skills. I think the model going forward, there's some piloting about more involvement of general practice and widening the availability of access to gender services via GP-led clinics. There's a pilot in Manchester, and the outcome of that will be very interesting. Another thing is that it's not just the clinicians in the gender dysphoria clinics that we need to think about. So all of the surgeons are getting, well, they're not getting any younger like me, and they have there are no training pathways to be a masculizing chest surgeon or a genital reconstructive surgeon. So again, it relies on people having transferable skills, having an interest, and wanting to pursue that interest. And it's a little bit like Martha. It's people who are doggedly carving out something because they're passionate about it, rather than a sort of laid out career pathway that people can follow. So I think there are some barriers there, but if there are more people pushing at the door, I think that will encourage those training pathways to develop.
Someone's written about the med school curriculum needs changing relating to LGBT and trans healthcare. I am working on it. It's happening. The second years are getting a lecture next week, I think, which is a bit of a surprise because I thought they were getting a lecture at the beginning of November, and now I'm slightly panicking. But anyway, and then the fourth years are also getting a GP tutorial case thing, so we're working on it, just as an FYI to that comment. But anyway, we can now hand back to the far more interesting people than us. Thank you.
Martha's also helping plan a session for the PA course. Not that anyone's a PA, I'm just like, woo, PAs! But Martha, Oscar and I and our DPD, Emma, we've been planning a trans health session for the PA course as well.
Yeah, it's basically just trying to kind of infiltrate it early on and just get them to kind of add sessions in at the moment. Ideally, it will be compulsory in a couple of years to have LGBT training, trans specific training, like that is the goal. Although my PhD is not working to get it put into the curriculum, because hopefully that will happen in the next couple of years anyway. My PhD is going to be focusing on kind of medical perspective. So like I'll do like surveys at the end of workshops and stuff like that and ask people, do you want this in the curriculum full time? And if I get results that justify it, we can push this out and really kind of enforce impact. And like I said before, it's the awareness. And, the more awareness we have, the more voices and support of getting training actually added to the curriculum and stuff like that is definitely doable. And I think I'm in a lucky situation where I have this kind of working relationship with Martha, where we kind of work together to kind of do these workshops in a way that has a trans perspective as well as a medical perspective. And I think that's the kind of ideal situation that you'd want, especially in these kind of teaching areas, and to make them as open and transparent as possible, definitely. So it is something that has been worked on from many, many angles and all sides of it. And it is something that I'm going to keep kind of pushing from my role in the university and things like that. I do also work with the Rainbow Network, which is the staff LGBT network at Newcastle University, and I have brought it up to them that the curriculum lacks any kind of LGBT. I've brought up that there's a lack of Black queer literature and things like that, and I am doing the best that I can to absolutely enforce that into kind of, I will be getting in contact libraries, and I think we're coming up, I think Lou's in the group as well, but we're coming up with an action plan to do things to actually make it better in the university. And like we said before, we've got the trans staff policy coming out now, which is very much thanks to Lou, and things like that. And so we are kind of moving forward as a university to kind of make these things a lot more better and to kind of lessen the microaggressions. I also think I saw a question about transphobia in medical profession, or is it a lack of knowledge? That is a really interesting question. I think it can be a bit of both, really.
Mm-hmm.
I think you can get some outwardly transphobic practitioners and things like that, but a lot of the time it's stigma or discrimination is often perceived when when the practitioner isn't knowledgeable in the area. So, for example, you go to a doctor and they have no idea what you're talking about. That's what it's like for some trans people when they go and try and explain about their gender. And the way you come away feeling that, you feel like, well, if they don't know what to do, am I valid? Like stuff like that. So it's that kind of perceived discrimination can also happen as well, but it does generally affect well-being and mood and stuff like that. So whether it is blatant transphobia or just perceived, the idea is that the more education, the more training, the more like awareness in general will mean that trans patients are less likely to face prejudice and discrimination, and that if they do, there's clear protocols surrounding that they can, you know, act on and get the right treatment, or that practitioners won't kind of be shown to be discriminatory because they don't have an understanding. The idea is for everyone to have like at least a basic understanding of what being transgender means and stuff like that. So I hope that answers anyone's questions.
Okay, I actually have a question.
You did before, didn't you?
Yeah, so I'm quite keen to know, sort of shifting from a structural perspective to an individual perspective, what's been useful for you guys in terms of your own mental health? And, you know, are there any kind of like top tips you'd give in terms of maintaining it, and any other advice to future doctors?
So I think for me, experiencing dysphoria and things like that is obviously really, really difficult to go through, especially as I said before, when female functions start coming in and the time of month and things like that. It does make it a lot more difficult because you just don't sit right in your body. I found that meditation works quite well for me. I picked that up from a psychologist I saw a couple of years ago, who kind of wasn't kind of aware of gender dysphoria, how that worked, but really tried to kind of give me coping mechanisms that would kind of work with my dysphoria. At the time, I like quite sensory stuff, and I like to ground myself with like smells, touch, like things like that. So I'll normally have like a hot shower with some nice shower gel and stuff like that. But when I'm dysphoric, that doesn't always work. So meditation has kind of always helped me in that way, in that you can just kind of let the thoughts in and just let them by. There's also a lot of like visual meditations you can do as well. So in terms of like, you can imagine yourself in a different body, for example. So when I meditate and I create this like visual imagery in my mind, I don't look the way I do now. I look like the man that I want to be and the man that I'm hopefully going to become one day. And I think that has kind of really helped me with just being able to kind of relax and stuff. I also think like being trans-masculine as well it can be difficult to kind of talk about your feelings sometimes, because there's a toxic masculinity and things like that. There's this idea that you shouldn't talk about your feelings, and you know, real men don't do that. But I think it's like accepting that it's a really hard journey you're going through, and you're not in it alone, that people around you, although they might not have the exact same experiences as you, that they will understand that what you're doing is hard. And I think having a support group of my friends and stuff has been really, really helpful for just managing kind of any anxieties that I get.
Yeah, I think, well, I also do a lot of meditation and yoga. I think just like a lot of the yoga that like my teacher does, like about having an awareness of your body, but not what it looks like, but how it feels and where it is in a space and stuff, and like the things your body does for you, like the way it carries you throughout your day, and none of that's to do with like what it looks like. It's just, you know, like the function of your body, I guess, and the fact that you have arms and legs and a tummy and lungs that breathe. And also, I think just talking to people is really important. I think I'm a very talkative person, but having a good support network and even like reaching out to people, but also like knowing your limitations and setting boundaries. I think sometimes it's hard when people are struggling themselves to take on other people's worries, and I think saying like knowing when to give yourself space and when to take some time out is also really important. And just doing things you enjoy that don't involve you thinking about your body or where you are or where you want to be or who you are and who you're not. So just things where you can completely immerse. So for different people, that's different things, whether it's music or film or cinema or reading or like, I don't know, getting lost in a story, just taking yourself away from like our world. And I think at the moment with like everything that's on everyone at the moment, like there's like seasonal affective depression, and then there's like pandemic depression and quarantine depression and like all of the other kind of things that mental health anyway, like on top of going through all of those in a global pandemic, and it getting towards winter and it being cold and dark outside, it's just like managing, like it is really important to stay on top of things and give yourself some time and just go easy on yourself. Like no one's perfect, and like definitely stepping away from social, sorry I'm really rambling now, but taking time away from social media is really important.
Should I? I have to add the comorbid neurodivergency on top of my dysphoria. So certain therapeutic avenues are not useful to me. Meditation, not useful. Mindfulness, frequently not useful. I have to deal with emotional sensory overload as well. So the emotions that are very loud, and alexithymia as well, in that I may not notice I'm sad until I'm crying, that kind of thing. That's kind of the emotion. I don't have that emotional intelligence. I can't detect that. So things I have to use neurodivergent coping strategies, which may not be applicable to neurotypical people. So I will tend to resort in, rather than doing things that require focus, I will tend to resort to things that are essentially stimming. I will do repetitive physical tasks. I run, even if it's for a short period of time, because firstly, I get the vitamin D in the daylight and break down melatonin. It's a repetitive action, so it's soothing. And also, if I have built up a great deal of adrenaline and anxiety, and I'm starting to feel stomach pain as a result of it, I can burn that off with the physical exercise. Exercise is not available for everybody. I'm aware of that. I have enough friends with chronic fatigue disorders, but that is helpful for me. So it has to be repetitive and non-focus based actions that will help me manage it. In common with the neurotypical people, the value of having the support structure, and specifically a support structure that use the correct pronouns for you, that refer to you with the correct language, that do not that's people in your life who you can spend as much time around, who do not repeatedly re-traumatize you, who don't so that the microaggressions that you get are kept to a minimum. And I do not spend time by choice around people who will not do that, because that is another load of kind of repeated re-traumatization on top of me. I tend to, I'm afraid, not look in the mirror a lot, because then I don't have to deal with the sensor minimally, like the amount of time it takes to make myself look presentable, not look at my hips, just basically not that sign stimulus, not let it occur, which is probably avoidant, but it helps me survive. So there we go. Yes, so not necessarily applicable to if your patients are not autistic dyspraxic, but if they are, there you go.
Yeah, definitely. I think in terms of obviously what you can do as medical students or like working in medicine, I think from research I've done, I think I got a few like main points out of it. So it's like basically 5 main points. Don't make assumptions. Don't make assumptions based on people's gender, people's sexuality, things like that. If you're not sure, ask. People would much prefer that you ask them rather than make an assumption and get it wrong, because as Lou says, that can make the experience traumatic and lead to anxiety and things like that. Have an awareness, that you will be dealing with gender variant patients, you will be dealing with trans people, you will be dealing with non-binary people, and kind of just treat them the same way that you would. Have like an awareness when you're kind of looking at treatment plans and things like that. Just keep that in the back of your mind that this patient might not fit the regular path that you would usually refer to for that treatment, and hold yourself accountable. I think that's really a big one in medicine and things like that. So it's not the patient's position to educate you. You have had years of training and things like that, but it's not on the onus of the trans person to kind of educate you about their healthcare and what they need from it. It's always good, like I said before, to have a basic awareness and a basic idea of the processes and things like that, so that they're not there having to sit and re-educate you. Because like I said before, if they're having to tell you, it kind of creates this perception of the practitioner not having knowledgeable or being dismissive, which can lead to kind of feelings of discrimination and stigma and things like that. Affirmation. So, definitely trying through a patient that you have leaves that interaction or leaves that appointment feeling that their gender, sorry, is my internet working, that the patient is feeling validated and things like that. And then like I've mentioned previously, autonomy with their own identity within the treatment plan, what they're going to do and things like that. So I think that's my final point.
Okay, great. Charlotte, Lee, would you like to add anything to that?
Yeah, I back up what Oscar says, and also remembering that transition isn't a one size fits all, and what one person wants isn't what everyone will want, and that because if someone doesn't want hormones or doesn't want surgery or doesn't want anything, or they just want to socially transition, people can socially transition and medically transition, and some people want one and some people want both, and remembering that if someone doesn't want something under the transitioning umbrella, it doesn't make them less trans.
Okay.
I'm not really sure what I can add to that, really. I think, yes, as every transition, and to be honest, every patient is unique in any context. Unfortunately, we have to group them in order to find out what treatment, especially in clinical research, in order to find what what things work. They do have to be grouped. But in this case, it is very, very easy to box people or make assumptions about people, and that will be detrimental to the care in trans people, just because the baseline is frequently so inaccurate. We know how a heart works. Gender dysphoria is still, I guess, frontier medicine to some extent, despite how long this has existed. I mean, I understand you're having difficulty getting the right, training people and finding a pathway, carving out a pathway for that to be the case. So I hope, I'm glad that things are changing so dramatically and rapidly. But yes, I don't know what else I can add apart from that, really.
Okay, thanks a lot. Does anyone else from the audience have any questions? Because then, if not, we'll move on to Martha's final segment. So if you want to ask anything, feel free to post it in the chat. In the meantime, I'll set up the share screen.
I think someone asked something about how do NHS services compare to equivalents in other countries, and I guess it's the only thing that I've noticed in the chat that hasn't been addressed really. And I'm going to look at Dr. Shaw for this because
better in some places and worse in others, I understand. Belgium is pleased to be doing very well.
Yeah, we only really know bits, I guess, as a practitioner. I think there's health policy for gender dysphoria certainly has a kind of political element to it. So the that's the understatement of the day, I guess. Yep. So you can see a changing environment, say in the States at the moment, and that's interesting because they've got a private healthcare model. So in some respects, there is a more open access and possibly access to things that we wouldn't do here. But in a environment where I think there's a general increasingly hostile environment to diversity. So the States is quite a weird, it's always a weird place in terms of healthcare and health policy. In Europe, I guess the sort of the European countries, the EU countries are not dissimilar to us, but they have different funding models for healthcare, and the structure for delivery of care can be quite different. It's probably worth saying that I guess we're talking about lots of little levels. So the bit I know about is about treatment of gender dysphoria, but actually what we're really talking about today is access in general for healthcare to people with varying sorts of diversity, but we're particularly talking about gender diversity, and delivery of primary healthcare in the UK is quite a different model from other health services. So it's really, I guess that's a very long-winded way of saying it's kind of like sort of apples and pears. It's really hard to make comparisons. I hope that doesn't answer the question. I hope I've not answered the question in a satisfactory way.
Well, I mean, from a patient perspective, comparing my experience to that of, say, Belgian friend, US friends, French friends, like Western Europe, it seems to be easier and rapider to access treatment, possibly because of their mixed insurance state-funded model. The US, it seems to be easier to access treatment as long as you can pay for it and your insurance covers it. But that is, as you say, US. It's a shame that so much research is done in the US environment, since when it's so drastically different to almost any other healthcare environment in the world. So we're working off often working off a weird example. And I would say our waiting times are extremely long compared to places that work on an insurance model of one kind or another. Eastern Europe, places like, once you get into places where the environment is actively homophobic and transphobic, you will have real difficulty accessing anything, but that's not altogether surprising, to be honest, in those contexts. So my still view is that we're worse than some people, better than others, and you're correct, there's no real answer to that, is there? Like, it is very much apples and ham, essentially.
Okay, excellent. So I think that's all of the questions, which means we'll then move on to the final segment. I'll share the screen. Okay. Can everyone see that?
Okay, so I guess as a clinician, a lot of this has already kind of been brought up in the panel discussion very well, and a lot of kind of stuff around Oscar's research has talked about this, but in terms of kind of things you can do as a clinician, just to summarize, I guess, so making sure you are using all your communication skills, and kind of ideas, concerns and expectations are kind of, the thing that we all get nagged about in every OSCE practice that we have ever done, are actually really important in real life. Who knew? So kind of using all your communication skills and making sure you're finding out what your patient's wanting and what they're worried about, and kind of is great. Using correct names and pronouns is so important, and like we said earlier, if you do make a mistake, apologize and then move on with what you were talking about and try and not kind of dwell on it too much. And thinking about kind of the language you're using as well, and if the patient that you're talking to has any kind of preferred language that they'd like to use for their primary and secondary sexual characteristics, you could ask them about that and then use the language that they're telling you to use. So for example, a lot of trans men will prefer to use the term like chest to talk about their chest area rather than breasts, as an example. But obviously each person will be individual and different and will have certain terms that they might prefer or certain terms that they might want you to be avoiding. So next slide. But yeah, in terms of like general clinical stuff for non-gender related care, think about what organs someone has and how that might change your differential diagnosis. But it's also really important to remember that not everything is going to be to do with someone's transness. So if you've got someone presenting with like say abdominal pain, trans people can get all the kind of non-gender related causes of abdominal pain too, like appendicitis. And it's important not to just focus on the fact someone's trans, but see them as an overall person, but also to think, do I need to think about organs that you have that maybe I wouldn't necessarily expect you to have at first glance, if that makes sense. And thinking about kind of when you need to ask about those organs and when you don't. So if someone's presenting with kind of lower abdominal pain, it's probably a good idea to know whether they have a uterus and ovaries, because that's going to really change what your kind of differential diagnoses are. So that in that case, you probably do need to ask about that. But if they're presenting with kind of tingling and kind of carpal tunnel syndrome symptoms, you probably don't need to know what they've got going on in terms of uterus and ovaries. You just need to know about the nerves in their hand. So then it's probably not appropriate to ask. So just thinking, when do you need to know and when don't you? In terms of kind of clinics and wards and things, if you're admitting someone to hospital, the kind of general rule of thumb is that your trans patients should be nursed on the ward that matches their gender identity and gender expression. But if you're not sure what someone's wanting, then the best thing to do is kind of ask that patient, like, what would make you feel comfortable, and then they can tell you what's going to help them. And in terms of kind of referring for appointments and things for certain things, like for example, if you're referring a trans man to kind of obs and gynae, it might be nice to think about kind of how you can make them feel comfortable during that experience. And one of the things you could consider is asking obs and gynae for like beginning or end of clinic appointments, so that people aren't kind of hanging around in the waiting room in quite a gendered environment for like a really long time while the clinic's running late or whatever. And I guess just remembering, like, curtains are not soundproof. We have this great illusion in the NHS that they are, but they are in fact not. And thinking about how you can make sure you're not outing your patients to all the other patients around them on the ward. So thinking about if you do need to talk about something to do with their gender, then do that in a nice private room, not in the bay. Making sure you're using the correct names and pronouns, even if that's not necessarily what it says on the medical notes that you've got in front of you. And kind of just thinking about the little things, like we have those kind of urine bottles for people with penises. So if you've got say a trans woman with a penis and you're bringing her those, you're very much going to be outing her to kind of the whole bay if you're not doing that in kind of a subtle way. And if you've got a trans man who doesn't have a penis and you're bringing him those, like, that's a bit useless for his urination needs at that point. So again, probably worth kind of, thinking about. And lots of little things like that can kind of make the difference between kind of providing someone with really good care and people kind of feeling uncomfortable. So yeah, they're my, as a clinician, top gender comfort tips, clinical tips kind of thing. But I'm sure people might potentially have more things to add on to that. If you wish to add things, feel free.
You only make that curtain mistake once.
Yeah, we have a very bad habit of being like, no one can hear through this piece of fabric.
Someone needs to invent soundproof curtains. I think that would really help the
But yeah, cool. I think that's everything from my perspective. Oh, some good resources if you're wanting to find out more. This book is really good. It's written by a non-binary person who is not themselves a clinician, but has got lots of like input from clinicians in writing the book. So, and it's very, you don't have to be like a gender specialist or anything to read this book. It's very much like medical students fine, GPs fine, very accessible, strongly recommend. And the Gender Dysphoria Service website has quite a lot of kind of more in-depth information as well about things like hormones, and they're presented in like information sheets for patients, so they're quite like an accessible read and like quite easy to understand in terms of like explains it in quite kind of uncomplicated language, so quite a good starting point if you're wanting to kind of look into the medical side of things a little bit more. So yeah, they're my kind of top things to look at if you're wanting to find out more information.
Okay, excellent. Thank you ever so much for your time, Martha, Dr. Shaw, Oscar, Charlotte, and Lou. Would you have any other kind of final comments to add? Anything else that you'd like medical students to know?
I'm all good. I think I kind of said quite a lot, so.
Yeah, I'm out of ideas now.
Just say generally in life, don't ask LGBT people questions that you wouldn't ask a cis or straight person. So you wouldn't ask someone that you thought was cis or straight what kind of genitals they have or how they have sex, or like weirdly personal questions, like just in general life, don't ask them to
Except
people.
in a necessary clinical context, yeah.
Yeah, unless they're like entirely necessary for the clinical context, then just think about the questions you ask people and if you would ask them to someone who wasn't trans or queer. Okay,
great. Well, thank you once again. Thank you, everyone. And thank you for all the audience members coming and spending your Wednesday evening to learn more about such an interesting and important subject to lots of people in the country and around the world. So yeah, if you'd like to find out more, then the book that Martha recommended is excellent. And if you'd like to hear more about PsychSoc, we're on Facebook, we're on Twitter, we're on Instagram. I'll quickly show you that. So yeah, that's us. We're on Facebook at NUPsych, Instagram at Newcastle Psychiatry Society, and Twitter at NCL PsychSoc. So once again, thank you all ever so much for coming, and hopefully we'll see you at our next event, and hopefully you've learned something new today. So thanks a lot, guys.